Good afternoon, everybody. Yes, thank you very much for the time for me for presenting this paper on the post-COVID health system reform in Indonesia. And I think this will be an interesting discussion with the previous speaker, Prof. said about the Malaysians' experience. And this is about how the Indonesians trying to have the policy of reform. And then let's go to the history of reform in Indonesia since the last 20 years. And then from COVID to health law, we have some activities, and also the progress and challenges and the next agenda. So when we look at back to the introduction, the theoretical concept, yes, I agree with Prof. said that maybe we have to use this definition of health sector reform as a sustained, purposeful change to improve the efficiency, equity, and the effectiveness of the health sector. And this is a very interesting issue when we talk about purposeful change. That means we have, in terms of policy-making process, that healthcare reform is like a intended policy. It is not done by maybe luck or coincidence, but it is like a plan or intended policy that is trying to improve the efficiency, equity, and the effectiveness of health sector. And this is the things that I'm trying to talk about. This intended policy is not easy. So when we discuss about the Malaysians' experience this morning, we do understand that it is politically complicated. Is that right, Prof. said, yes? Yes, this is the same happening in Indonesia. And maybe it's much more forceful in terms of conflicts in how we shape the health reform. And then if you look at back to the classical theory about the coordination of many health policies, there's a metaphor, like the 5 contour knobs for health sector reform. It is coined by Mark Roberts and et al. At the Harvard University about maybe 30 years ago. Yes. And if we look at reform, we can see that there is a partial reform and there's a real reform. It's a big reform that needs all combination of policy change. It's not only one policy. So like this sound system, this is not only one component, but many components like the computers, the speakers. So the health system consists of financing, payment, organization, regulation, and behavior. And it should be simultaneously and at once should be combined or coordinated policy for achieving performance goals here. So we can see that using this metaphor, it is impossible to have like a full comprehensive reform. Reform is only talk or maybe implemented only for, say, financing. It should be all of these things becoming in one big real reform. And that is the things that we have to look at the theoretical concept. Number 3, we have also the reform objectives that we have the intermediate objective for improving access and coverage, improving quality and safety, generating new resources of funding for the services, and also securing legal certainty. And the ultimate objective, improving health status and equity. Again, this morning, it's very interesting that most of us choose equity as the best or the most popular word for reform objective, increasing responsiveness, and then how to protect from catastrophic illness and also improving efficiency. Okay. So from this theoretical concept, then let's discuss about the past of Indonesian health system reform through historical perspective, and then how the COVID-19's impact on the reform policy. It is not a coincidence, but it is like cause and effect, something like that, and how the transformation policy and the youth health laws is designed in Indonesia. So my presentation is like a story about the journey of health reform in the past, present, and maybe the future of Indonesian's health system. It is not easy, and then again, still a big question: how the future of Indonesian health system will be. I said the reform will be important factor that influence the health system or becoming just another paperwork for us. Okay, let's go to the first about healthcare reform story in Indonesia. Actually, the story is not the long or the 100 years of history, but more in the at current history, maybe the last 20 years. And we started with the trajectory of political reforms in 1999. And then we can see from the political books of political reforms, we have experience when our late President Suharto, he stepped down from his presidency, and many political party and academics, they are disappointed with the too strong role of central government. We are too bureaucratic, too centralized, and everything is dominated by the government. And then there is a movement to reduce the government role and trying to decentralize the political power into many units and also to the local government and also some central government units. And this includes the dynamic of reforms in health sector. So we are also like influenced by the political reform in 1999. And then putting this reform, we have some various law in health or related to health, like decentralization policy in 1999 and 2004, Medical Practice Act in 2004, and Social Security in 2004, followed by BPJS Act in 2011. Also, there were around 10 health related laws. So we have so many regulations, so like a jungle of articles and clauses of regulations. And this law were not synergistic. So, and actually it's not comprehensive like this theoretical concept by the Harvard people. This is more like a partial reforms in the health sector. It is done not in the total reform. And one of the biggest partial reform is the financing reform with social security laws in 2004 and 2011. But there is no human resource reform following this financing reform, no medical service reform, no primary care and health promotion reform. And then also it is noted in a weak government for governing the health sector. And that means we have problems of leadership in health governance. That is the situation before we have the pandemic. And then the condition of the health system, we are not effective, efficient, and equitable, and the government has limited power in regulating and also controlling the health system. Okay, this is the health indicator data. If you look at this is the red and the green one. The red is still not achieving the target, and the green one is okay. But although some is okay, but it is not equal or not in terms of equity well distributed across the regions. So Indonesia is an archipelago country. It's different with maybe Thailand is a landmass country. Malaysia only two big mass land, okay, in Timur and in Barat, in West and is Malaysia. But we have about 13,000 islands from this is Madrid to Moscow. This is the size of Indonesia. So we can understand that the problem of disparity, regional disparity, is so devastating. And we have also unsustained funding system. Okay. And then if you look at this is not only domestic, but we have also international problems. If we compare with fellow ASEAN countries, then many of the data show that we are still lag behind the average of ASEAN, like for NCD deaths, and then maternal mortality rates, infant mortality rates, and this is very alarming. the number of smokers is going up and up and up, and it is we are the champion of smokers in the ASEAN regions. So that is the big problems in Indonesians compared to international standard. And then because we don't have reform in human resources as an archipelago country, we can see that there is a poor distribution of specialists and head human resources. And again, Java is the most populated island and the most deployed human resources. It is very clear. And then we can see here, there is an inequity of national health insurance or BPJS claims spending. If you look at this graph, this is regional 1. Here is Java Island. And then region 5 is East Java, okay? In Java, in the last 7 years or 8 years, yes, it is increased very sharply. But when COVID struck, it is go down because the COVID. But if you compare to other regions, especially in East Indonesia, this is a very, very alarming feature that in the East East Indonesia is stagnant. So the claim of the insurance benefit is very, very fast growing in Java, but not in eastern part of Indonesia. And this is the biggest inequity problem in Indonesia. And then let's go to that Prof. Said mentioned about the social insurance scheme in Indonesia that we, maybe Malaysia should learn from Indonesia, that we have the paying members and the non-paying members, okay? And we have problems of the paying members. In Thailand, you don't have paying members, all paid by the government, okay? But Indonesia choose the way of doing paying members, and the paying members should be the middle and the upper class of society. And they're becoming members in the PGS, in the social health insurance. And the problem is they take the most of the medical benefits because they have better access, and also they have more financial support because the scheme is only paying the hospital costs, but the accommodation, the transportation, the food for the family that care the patient at the hospital, no. Okay, so we can see that using this kind of payment system or reimbursement system or supporting system, if poor family, they are maybe in hospital for a week and maybe not recovery, they just say to the hospital managers, we want our family opting out from the hospital. So discharge from the hospital, not by medical order, but by because they don't have enough money for supporting their family at the hospital. Okay, so that is the point, that if you look at this graph, because we are single pool, and in Thailand, although you don't have any paying members, you have 3 pools, yes. But in Indonesia, every members, every segment in one pool, and that means it can be cross-subsidized. That is the point. Yeah. In Thailand, the poor cannot be the budget for the poor cannot be used by the government employee pool, something like that. Yeah, you have 3 pools in Malaysia and another free pool for medical commercial insurance. But in Indonesia, only a single pool, and this is my debate years with some of the health insurance researchers in Indonesia, also in the World Bank and the people, that this is the danger of single pool. But if you can see this, this is the surplus members, and if you can see this, the highest one, this is the poor members that paid by the government subsidy. Okay, and this red one here, this is the paying members, and actually there are more maybe affluent than this member. Okay, But you can see that since the beginning, the affluent members, it is making deficit. So the price of premium is too low compared to the cost of medical benefit. Okay, so you can see that. In the years of COVID, it is declining like this, but now it's becoming more and more claim to the rich member. Okay, so this is the unspent budget for the poor. They are not ill, no, they are ill, but they don't have enough access. That is the point. Okay, so that's why there is an unspent budget for the low class, for the poor people, and the budget that should go to the poor, it is used by the rich member. So that is the problems in our social insurance using one single pool system. Okay. And also, if you look at back to the spending is very flattening. It's flattening around 3% of GDP, like this. If you compare to Malaysia, it increased year by year. Also in Thailand, also increased year by year, and also in China. But Indonesia is flattening. And this is we are very concerned. This is my hypothetical analysis, and many people, they are not happy with my my comments because many of the rich person, they are relying on government subsidy if they are sick. They don't want to go to pay by their own pocket. They don't buy medical insurance by in terms of using commercial insurance. They're just relying to BPJS, and this is the danger of single pool system. Okay. And this is the role of private financing is marginalized. Coordination of benefit between BPJS and private medical insurance is not well regulated and happen. And huge private financing using cross-border system to overseas hospital services, including to Malaysia. And the last figure is about 800,000, 700 to 800,000 Indonesians. They go annually to Malaysia for medical treatment. Okay. And then also this is my hypothesis. Affluent people is also relying on social health insurance, which is heavily subsidized by central and the local government. This is becoming problematic if we look at back to the how strong is our financial capacity, our government, to pay for this so-called middle and up people. Because Indonesian tax collection is only 9% of the GDP. We will discuss later on, but in comparison, in Thailand, I read about 16%, 16%. In Scandinavian countries, around 25 to 30%. Yeah. But Indonesia is only 9%. And this is very, very weak financial resources for welfare activities. Okay. And then also, if you look at the government role, before COVID-19 pandemic, the government role was weak, yes. More power actually is held by private organization such as medical association since the medical act, medical practice law in 2004. Yes, so it's like the story is like a swing in the colonial past. We had strong government role, but in 2004 there's like a swing to the private. Yeah. So actually, health system government was not implemented in a good condition. The government is not so powerful in terms of allocating or distributing medical workforce. Okay, so historical facts in the last 20 years, no evidence of a comprehensive health system reform after political reform in 1999. So this is the facts. Yeah. After we did a study on historical analysis, and if you look at back to the before in 95, 96, 98, we didn't have any reform. Okay, so from this situation before COVID, then we we have the COVID-19 period from 2020 to 2023, and we can understand that every country was very, very hit by COVID-19 pandemic in early 2020. The same in Indonesia, and we fought very, very hard to keep our health system not failing down. Yes. And then this is the Ministry of Health Strategy, and this under presidential order that we have three activities that MOH should do. One is accelerating vaccination at a time, and then two, ending the pandemic as soon as possible, and three is reforming health system. So you can see that under the presidential order, the term of reform already coined or already in the beginning of COVID-19, because we understood very well that before COVID, the health system was so weak. Even for the oxygen distribution, we have a big problem during the COVID. Also for the drug supply, vaccine, many things. Yeah. Okay, so the government of Indonesia plans a health system reform that accommodate the increased community needs attributed to COVID-19 pandemic, keeping UHC coverage, the universal health coverage, and sustaining essential health programs, while this is the point, improving the pre-pandemic health system weaknesses. That is our strategy. And coincidentally, I was recruited by MOH to be one of the advisors for the minister. So I was at the Gajah Mada before COVID, but when COVID and after COVID, I'm now in MOH. I have to choose at the moment, one in Gajah Mada and one in MOH. Until this October, I will return back to Gajah Mada after the new cabinet. Okay. So my Minister of Health, Mr. Budi Gunadisadikin, and he is not a doctor actually. He is physics, from Institut Teknologi Bandung. If you know Bandung, I think ITB is the most famous technical engineering university. And he preferred to use transformation for this reform. And then his idea is how the pre-pandemic health system should be transformation to the post-pandemic health system, and then using the learning process from the pandemic experiences. So this is very interesting principle that we went at the time for the future Indonesia. So what is the difference between reformations and transformation? It's like it depends on who are you, who are the speakers. But actually, our interpretation is this is like the acceleration of health system reform with transformation principle, like how to transform from like caterpillar, as the ugly one, becoming beautiful butterfly. This is transformations. So this is the idea, and it's very, very interesting word to attract people to think about not using the reformations, but transformation. And it is already used in the business sector, and our minister, he was the director of the biggest bank in Indonesia. So he knows very well about how to use the word, the beautiful word, transformations. And then this is the things that we learn. We do understand that there's like the classic metaphor of reform. So turn by 90 degrees, something like that, then becoming like the house of health transformations by MOH. So this is the vision. The same is the performance goal. The vision is how to produce a healthy, productive, and independent and just people. So about equity, about fairness, about healthy and productive life, something like that. Okay. And then instead of the components, we use the 6 pillars from primary care transformations, secondary care transformations, health system resilience transformations, health financing transformations, health talent, human resources transformations, and health technology transformation. So you can see that this house of transformation is like the whole concept of total reformations by the Harvard University researchers or scholars, something like that. Very similar, actually. And then this is the biggest problem is how to make it into one big reform policy. It is not easy. Because why? The question whether transformation will work, this is only can be on paper. Maybe yes, or maybe no. Yes. So the minister understands that without a strong legal basis, transformation cannot take place. And it is very nice things, maybe shared. Yeah. We have so-called omnibus law principle. Yeah. So we have so many laws related to health before, more than 10, 11. So we are trying to put into one, to cancel the 11 laws and then make it into one big law. That is so-called omnibus law. Like omnibus is like a big bus, yeah, omni, eat everything, omnivora, this is omnibus bus, yeah. And then we note that before 2023, the government position in the health sector was weak. So you can understand that this is very, very interesting process. Because it is after a conflicting period of lawmaking, almost 2 years, we had a very big fight in Indonesia. On the 8th of August, the government enacted health care law number 17, 2023. And this is, we use it as a legal basis for health system transformations. And there's a strong political will by the president. So it is very clear that the president and the minister, they want, they demand healthcare reforms using the terms of transformations. And they are willing, the president and the minister, also they are willing to change the law. The big law they have to write consists of 11. So if you look at from 1948 to 2019, there were 11 laws that is blended to the big law, except PPGS and SESN laws and decentralization laws. They are still not in the big law of HED 2023. Okay. But the process is, I think the same as Malaysia, is very political. And if this morning Prof. Seth mentioned about the lack of political will, we are very lucky that the president and the minister, they are very, very willing to push the law, the reform law, into reality. It's not only on paper, because actually the House of Transformation is like the white paper of transformations, but it is cemented by the head law. Okay, now the law already there, and then how the progress and challenges. That is the point that I'm trying to present for this section. And one issue is the governance aspect of health system that should be improved, and now is improving. Yeah, we are trying it. And this is focusing on the stewardship role of the government in governing and managing healthcare, and also coordinating other actors engaged in health policy formulation and its implementations. So you can understand that after 20 years of a weak government role in health sector, then suddenly the law trying to give more power to the government. And the story is not easy because a close power in health sector. I don't know in Thailand or in Korea, we can understand that it's very, they strike in UK also, British Medical Association is also strong. But in Indonesia, it's much stronger. The previous law mentioned that Medical Association is the only one is written in the law. It is like a government body, something like that. Yeah, okay. So this is very interesting. The government function by theoretical concept. We were under pressure to change. Yeah, and we can see that there are actors, many actors in the Zoom governance. And this is something that in the theoretical research on reform is not so well addressed. And when I listened to Professor Said speak this morning, yes, I understand that maybe in Malaysia you should have like how the power play amongst actors in health system. Even in political party you mentioned. Also the same in Indonesia, we have about 11 political parties. And at the end of the day, when we have to have like voting for the reform law, only two rejects. So the 9 political parties, they agree to pass the bill, becoming head law. But you can imagine that at the parliament is so complicated. So this is the things that we have to be very clear about the actors. And then also one main function of the government should be put into the reform agenda. That is, government role is to govern, making public policy and regulation, controlling the health system, and ensuring the effectiveness and equity of health service. And this is the things that in the last 20 years, we didn't have enough government authority for governing the health system. It's like the government is trying to take back their authority that already transferred to the private organizations. And this is under authoritarian government, is totally held by the government. And our history mentioned that it was in the Dutch colonial time, it was like this. All of the policy is held by the colonial government. But during the medical practice law 2004, our analysis, and it is debatable, it is built to the more private authority. But this is our new law is trying to keep in the middle, so it's becoming more stable. This is the idea of telling the people about what's happening if the governance and the role of government to govern is not put into the middle. We will be very, very unstable position like this or like that in colonial period. Okay, so the progress between August 2023 and July 2024, the government is legally strengthened for being able to formulate reform policies that provide solution to health and implement them better. So in the last 1 year, there's a battle of how to have the youth law consists of 150 articles, and then no, just past 2 weeks ago, we have 1,100 articles of government regulations. You can see that this is a huge, very, very big effort to write the government regulations into once. Because we have very, very bad experiences when we say or wrote a law, say 7 years ago, and the government regulation that are, say, about 7 to 8 in its law, some of the law cannot finish the regulation until 10 lower than law, using also omnibus government regulations. So that means 100, this is only some of them, like strengthening prevention and primary care, expanding the services across the country, financial capacity of government and community, how improving health resources, and many things. Okay, let's go to one by one. For example, this strengthening private and primary care. So how this indicators becoming more equity, more between Java and eastern part of Indonesia becoming more balanced. And then how strengthen the primary care and prevention program. This is very, very challenging. And then how the international comparison, including this is very popular debate at the moment using the cross-border patients like medical tourism, how to have better quality of our tax ratio data is declining over the years. So this is the tax ratio. Yeah. Okay. And this is the GDP, and this is the tax collection. because most of the tax come from the income tax, from the VAT and many things. So if we raise the tax, you can see that political consequences cannot be maybe like received by politicians that don't like the tax increase. Okay. Okay, so that's why we need more innovative financing. That's why we have, I agree with this morning also like survey, the quick survey that financing is very important. Yes. So now we are trying to encourage private insurance. So the affluent people, the middle and the rich, relying on the BGS. Or you can laugh at this very nasty anecdote. One of my friend is very rich. He has more than 5 houses, big houses. He's earning maybe more than 1 billion rupiah a year. Yeah, okay. And suddenly he had operation to take some of things from his body. And the government, sorry, the hospital cost is 20 million rupiah. And he is the member of the BGS. And then the condition of benefit is very funny that for this very rich person, and he is member of the BGS pay 19 million out of, it's only 1 million out of 20 million. And he is laughing for this. And I'm so sad. You are laughing. I'm sad. Why you are laughing? You pay only 1 million. Oh my God. And you have more than 100 billion in your asset. Only 1 million. And this is happening. Yeah. So you can see, Prof said, we have to be very careful in terms of how to decide health insurance in the future. In Indonesia, we are trapped because the insurance at that time, the BPJS, sorry, the social health insurance, is promoting to everybody from the poor to the rich. In Thailand, I look at Professor Supasit. In Thailand, UHC is only for the poor and the middle. Is that right? Yeah. Not for the poor. The UHC in not when I visited one hospital in Thailand, Sirirat Hospital, they have very like big promotion, proud to pay, because they have a private wings in Sirirat Hospital in Bangkok. The big complex is used for UHC. Okay, and then one of the I don't know corner, they built a tower. Yeah. Yes, you cannot, you can use the private wing, but you have to pay everything. It's good. That is the point, that UHC should be for the middle and the low class. Okay. Also, how to produce, distribute, and retain medical workers across archipelago is not easy, but we are going to that direction, including fulfilling the empty places through a new way in specialist training, the hospital base. Yeah. Executing task shifting. So some remote area, if there's no OBGY, the GP can do sexual cesarean, for example, like this. Yeah. And then also local governments should support for financing the specialists. So these kind of things that are trying to be supported by this new law. And then also working together with various professional associations, such as Indonesia Medical Association, after the conflicting period. Yeah. So after a very hostile conflict between Indonesia Medical Association and the government, and the Constitutional Court had rejected the IMA challenge February this year, then we have to make a good reconciliation with the Indonesia Medical Association. So we have to work together. And then also how the challenges of decentralization, how to bring this very big law into the 38 provinces and 540 districts and city. And then how to make the fragmented health system after decentralized policy becoming into one, and the BPJS, that a very, very centralized system, should be compatible with the provincial and district head office. That is a very challenging problems. Okay, lastly, what next in the future? So if we look at back to our experience, the health laws 2020 fulfills the requirement of reform which combines all norms. So we have set the regulations. It is a historical policy, and the political will is there. But it is not easy, yeah, to make all combined into one like this, yeah. So it's the same with this. And then we have to ensure for everybody, even the conflicting people, that health laws 2023 provides opportunity to achieve health sector reform objectives. That is very, very important things at the moment, because we just passed the conflicting years or months of lawmaking process. Now we have to set the tones into reconciliations and then trying to achieve together all of this ultimate objective. The last question, how the future of Indonesian health system will be? And in my opinion, depends on the implementation at the moment. So that's why this is a very room like us. Yeah. This health law needs to be monitored tightly by independent organizations. I will return back to Gajah Mada this October, and I changed my position, becoming more independent at the university. So I have prepared many projects for the so-called implementation research next year, and also evaluation research in the 2028 and 2029. So if this network still running next year, we will have some observations by independent groups about how the implementations of Indonesian health laws 2023. And then maybe in 2028, some of the like strategic issue will be evaluated. Okay, so using this kind of experience, I think we, as the policy researcher, we can have more opportunity to do our job because the situation needs us. That is the point. So as closing, I have some things that one, COVID-19 pandemic provided lesson learned from improving Indonesia health system. So in my humble or my frank opinion, without COVID, maybe we cannot achieve this reform. So COVID is something that make us having this reform. Yeah. So that's why after COVID, we have a comprehensive reform in health system, and then it is cemented by the health law 2023. The progress still in the implementation and starting with the government regulation last month in July 2024. And we have so many challenges that we can see from preventive and promotive increase until how we can reconcile of conflicting stakeholders. Yeah. And then health laws provides golden opportunity to reach the objective of health reform. And then lastly, it needs tight monitoring and evaluation through policy research by independent organization. Okay, I think thank you for this presentation. Terima kasih sekali. Yeah.